Our guest for this week's program is Dr. John Glaspy. His bio and information are on the website, so we won't take video time. Thank you for being with us today.
Oh, no problem.
So we're here to talk specifically about breast cancer as part of our E-wareness campaign. And while it seems an obvious way to ask the question, let's ask it. What is breast cancer?
Breast cancer is, in the garden variety breast cancer, the common breast cancer, is a cancer in which the lining of the breast duct has lost its ability to control itself. It's lost the instructions for good behavior, and that allows it to grow and survive when it shouldn't, and to spread.
Are there different forms, different types of breast cancer?
There are lots of different forms. There are only two that have enough commonness that it's worth mentioning, and the most common by far is ductal breast cancer, where the cancer arises in the duct, and the less common one is where it arises in the lobule that makes the milk at the end of the duct. And those two kinds of cancer comprise what we call breast cancer.
Now, what are symptoms? I don't want to say the symptoms.
So in general, the breast cancer can be nothing but a funny-looking area or some deposits of calcium on a mammogram, and otherwise be totally unsensate, unpalpable. You can't detect it with anything other than imaging. Or it can present as a breast mass, or a change, if it's close to the nipple, a change in the nipple and how the nipple looks, and whether it's inverted or normal in how it looks. Much less commonly, breast discharges and bleeding from the nipple can happen when with some kinds of breast cancer when they're close to the nipple. But by far the two most common things are abnormal mammograms without any other finding, or a palpable breast mass.
In terms of mammograms, would that be the primary screening and detection option?
It is right now still the best. To be a good screening test, you have to be widely available. You have to be validated so that there actually is some impact on the seriousness of the disease by doing the test. And it has to be something that is sensitive enough that it finds some breast cancers, and specific enough that it finds not a huge number of things that are benign that just scare everybody. So mammography's been around long enough that we have the validation data for it, and we know what its impact is on breast cancer outcomes.
Are there other screening options?
There's other screening approaches that are at various stages of development. The one that's most talked about is magnetic resonance imaging, or MRIs. Those have some advantages. They don't involve radiation, which is a good thing. They don't. They aren't as easy to defeat by glandular breast tissue. So they work in younger people where mammograms have their most trouble, because breast cancer stands out in a breast that's largely made out of fat, and breast cancer has an easier time hiding in a breast that's largely made out of glands. And when a woman goes through the change of life, her breast changes from largely glands to largely fat, and so mammograms are much more effective at finding breast cancers in older women. So MRIs might be a key for younger women. Problems with MRIs is that they are extremely sensitive, and they find a lot of stuff, most of which isn't the real deal. It's not what we're looking for, and so you end up with a certain amount of false positives that cause a lot of fear, and biopsies and those kinds of things. But MRI would be the next farthest along. The ones that haven't yet sort of found a place are thermography, reading the temperature from the different portions of the breast. But MRI probably will find a role in breast cancer screening, It'll get validated, and we'll know what its impact is on outcomes. And it's likely to be especially useful in young women who need to be screened, say because they're from a family with a risk, and useful when radiation is something you really want to avoid. There are some DNA repair disorders that predispose to breast cancer, and the last thing you want to do to those women, if you're trying to catch breast cancer early, is expose them to more radiation by mammogramming them more than once a year and damaging their DNA. So you don't want the thing that will find the problem to also cause the problem. And so we use MRIs now in that setting where a woman needs more screening, but you don't want to give her more radiation.
We want to ask about risk factors in a moment, but I want to touch briefly here on what of self-examination.
So, self-examination is something that everyone wants to believe in. There's a tremendous emotional desire to believe that self-examination will make a difference. It's empowering. It gives you something you can do. We don't have evidence that self-examination does what we ask of any screening test, which is it changes outcomes, that breast cancer mortality or some other measure of how bad the breast cancer is improves with breast self-examination. And what data we have say it doesn't change breast cancer outcomes. And if we're going to be data-driven and we're going to be honest with ourselves, then if believing something makes us feel better, but the data say you don't have the evidence of it, I think we do better if we don't believe it and demand that it show us something before we put any stock in it. And breast self-examination isn't going to hurt anybody as an activity. It might lead to some unnecessary biopsies, so it's going to have to prove itself in order to be. There's also a problem with false senses of security, that we really owe it to women when we arm them to give them a loaded gun. And we don't have evidence that breast self-examination isn't just a gun made out of candy, that when they get out there and they really need some help, it's not going to help them.
All things being equal, again, before we touch on risk factors, at what point should a woman begin the process of mammogram? I don't count what I read online. That's why
Sure.
we're talking to you. I heard age 40, but
so there are issues, and it's like everything, it gets politicized. So first of all, the risk factors. You only need one risk factor to be in the game of needing to have a awareness of breast cancer. You have to be a woman. Men don't get enough breast cancer for that to be something that should be on the radar screen of them to worry about. We'd all live to be 500-600 years old if the only thing men died of was breast cancer. But being female, you're in the game of this being on your radar screen as something to be concerned about. Other risk factors that raise within women a risk higher there are some mild ones like age at first pregnancy, and the younger, the less the breast cancer risk. Age of menarche, the younger, the higher the breast cancer risk. Age of menopause, the younger, the lower the breast cancer risk. Number of pregnancies, the greater, the lower the breast cancer risk. If you look at those risk factors, they're not real useful because they don't give a woman something that she would change in order to change her risk. Well, she's not going to say, I'm going to have extra children to get my breast cancer risk a little bit lower than other women. And she didn't have any control over her menopausal status or her menarche. Those things are just things that are wired. And so those things aren't real useful, but those are the oft-quoted risk factors. Family history is a strong risk factor, and the more the family history, the greater the risk, and there are a couple of defined genetic abnormalities, mutations in DNA repair genes called BRCA1 and 2, that confer very high risks of breast cancer and of ovarian cancer. And those are useful to know about because the risks can be high enough that a woman has the option of doing surgeries to prevent cancer. And those raise issues, and there's a lot of time and counseling that ought to go into it. But at least there's an action that a woman can take as a result of that. But there again, you don't choose your family. You're born, and you've got a mother with a family history and a father with a family history, and you don't get any say in that. That's something that gets dealt to you before you're born. And so there aren't too many modifiable risk factors. The rest of them are risk factors that are largely subsumed by common sense and taking good care of yourself for your heart. So most women don't die of breast cancer. Most women die of strokes and heart attacks. So a prudent lifestyle choice by women would be aimed at keeping their heart attack and stroke risk down, cholesterol, obesity, saturated fats. Those also are things that lower breast cancer risk a little bit. And so what you're doing for your heart works for your breast as well, to whatever extent you can. But the message here is that women aren't dealt a hand where they have lots of cards that they have the option to play with when it comes to modifying their risk factors. Largely the risk factors are dealt.
This is the hand you play.
Well, just by having two X chromosomes, you're in the game. You're a woman and you have a risk of breast cancer. And then within that risk can go really high or not so high, but it never goes low. And so, this is one of the reasons why breast cancer research is so important. This isn't a disease where all we have to do is figure out how to finally get people to quit smoking, and it'll take care of a big chunk of the problem.
Now, this is where the internet is dangerous, even when the website is the U.S. Centers for Disease Control. I read something that caught my eye, that there's a higher risk factor for someone who has started working the night shift because of the change in circadian rhythm. This is not a professional way to ask the question, but I'll ask it anyway. What's up with that?
So, there's lots of these observations that come out with one publication, that says this particular thing is something we observed. Aspirin, for instance. So aspirin, in one study that looked at women who were taking aspirin because they needed it for another reason versus women who didn't, it suggested that aspirin lowered breast cancer risk. And that spread through the population, and there's a logical reason to think it might because of this cyclooxygenase story that surrounded it. The problem is that subsequent studies that were larger and more focused didn't find it. So that observation stood there for a while and it made all the news circuits and all, but it didn't lead to something meaningful. We still have women and men take aspirin when they're older to try to lower their stroke risk, but it's not impacting on their cancer risk, at least so far as we can tell. So and I think this whole circadian thing is just yet another one of these. There are lots of them out there where there's been an observation, and I think in the fullness of time that'll be put into a perspective where it's not important. I'd also say, that people don't get, especially in this economy, to pick what hours they can find to work. So to torture them and say, you have to think about when you take your job whether it's going to affect your breast cancer risk. I mean, there are lots of small risk. Flight attendants have a slightly higher risk of breast cancer because they receive more radiation, right, than the women who are largely on the ground, because the atmosphere is protective. That's not a good reason to choose not to be a flight attendant. It's such a small impact on risk, and having a job is a good thing. And there are lots of negative health consequences that come crashing down on you if you don't have a job.
You rarely hear the astronauts say that either. I'm not going to go to space.
Right.
On the
Even
mission
though
of my life because.
Even though it will increase their cancer risk a little bit.
Right. So it's one of so many factors.
Yes.
Okay, let's advance to the unfortunate moment of you have the diagnosis. Now, what are treatment options?
Before we do that, can we so we mentioned that we know what our current screening ability does to breast cancer mortality, and we know, and you opened the question about 40 versus 50, so let's finish that. So we know that annual mammograms done right will reduce the risk of death from breast cancer, but they don't reduce it enough. And I think a good estimate, looking at all the trials that have been done, would be that it reduces mortality by 30% or a little less than that. So that means that 70% of the fatal breast cancers work out their fatal biology before they're big enough for us to see and detect. And that means we need to understand breast cancer biology better, and we need to work harder at prevention strategies once we understand that biology, and we need the research to make treatment better. Whether to start at 40 or 50 became a very big political issue, but there's a scientific reason why it's controversial. It's very clear that the younger a woman is, the more the mammograms have trouble seeing cancer, and the more schmutz that isn't cancer is around for them to see and call attention to and force a woman into a biopsy type situation. So the whole thing becomes less attractive the younger a woman is. And that age group between 40 and 50 is problematic for biological reasons. That's when women are still premenopausal, but they're approaching menopause. And mammograms work, but not as well as they do when women are older and are associated with lots of negative impacts like biopsies. You know, if you do enough breast biopsies, you'll kill somebody. You know, some bad bacteria will get in there, or they'll bleed, or they'll have an anesthesia reaction. Something will happen. So just saying we're talking about a fatal disease, so biopsies that are unnecessary mean nothing to me isn't good public health. I think good public health is to pay attention to that problem with false positives. And there's lots of room to question between 40 and 50 when money isn't the object. There was lots of accusations that the government was trying to restrict mammography to over age 50 because they didn't want to pay for it for young women, and that really wasn't. This should have remained a good scientific debate, and we should have seen people do a better job of keeping it there, including our politicians, instead of trying to make some soundbite hay out of a complex situation. And it's clear that the mammograms do more good than harm in women over 50. It's unclear whether they do any good in women under 40. Between 40 and 50, let's just live with it. It might play a role, but it's a small one in terms of helping those women. Now, you wanted to ask the question about you get breast cancer. Here's the good news. If you get breast cancer, you are very likely going to be cured. That's important for a couple of reasons. One, it's just good news. Two, there are women who don't have mammograms because they don't want to know, because they're terrified to get a phone call that says, we see something we're worried about, you have to come back in and we're going to find out what it is. That's taking that 30% chance and throwing it out the window and just saying, I'm going to be treated like somebody who lived in Appalachia and never saw a doctor in the 1930s. And I'm going to come in with a breast cancer this big, and then we won't be able to say you're more likely than not cured. About 1 out of every 4 women who get breast cancer aren't going to be cured. So it's pretty good prognosis if you have breast cancer just with what we've got now, and we're trying to make the situation better. The hallmark of treatment is surgery. We used to think, I wasn't around then and thinking, but medicine used to believe that when a woman relapsed after having had breast cancer surgery, it was because the surgery wasn't big enough. And so the surgeries in the 50s got bigger and bigger and bigger and bigger, and there was no impact on the breast cancer problem. And so in the 60s and 70s, the surgeries got smaller and smaller and smaller, because it was realized that the problem isn't that you're not doing a big enough surgery. The problem is that some of these cancers are systemic at the time they're diagnosed, and local treatments can't fix a systemic problem. And so once that got realized, then the role of systemic treatment as an adjunct to the surgeries came about, and there were lots of benefits from that. One was that many women didn't have to lose their breast anymore. In general, survival is the same if a woman has a lumpectomy as if she has a mastectomy. There are some exceptions, but that's generally true. And the systemic therapies improve survival. So the cure rates went up as soon as we figured out that giving some systemic treatment to a woman before you can see the cancer around her body on an x-ray was treating a woman who was potentially curable. And these adjuvant therapies, we're still fighting amongst ourselves about the exact what's best and all, but they've had an impact similar to the impact of mammography on breast cancer mortality. We're curing more people.
Starting right now, in that case, what can a woman do? The information that you're providing to us today, what can a woman do right now to reduce risk factors? As simple as take better care of yourself, take care of your heart. It affects all aspects of you. Once you hit 50, get the annual mammogram. I'm thinking of the easy things I'm taking from what you've said so far. Give us instructions. What can a woman go do starting right now?
There's something even more important. So we're just talking about breast cancer, not about general health. But recognize that breast cancer is a restricted part of your general health. But one thing a woman can do is to not accept the pablum of well-meaning public health people who say, get a shower card and examine yourself and get your mammogram every year and you'll stay out of harm's way. That isn't true. You will still be in harm's way. You will have loaded the dice a little bit better in your favor, but you're still in harm's way. And do something about that. Join an advocacy group. Make sure that at the federal level that we don't forget that we still have a problem, and that this isn't a problem that anybody opts into. We talked about risk factors. It's not something that you have control over, and that all women, any woman in this country, has a significant chance of getting breast cancer, and that should be unacceptable to everybody. And we should be getting smart and forcing our government and our scientists to stay focused on this in a way that's best for women. And there's no better group to do this than the women. And so do that. That's probably more important than anything else. Start having annual mammograms. If you have an average family history, not a particularly outstanding family history, start having mammograms for sure when you're 50. And to be prudent, starting at 40 makes perfect sense. And continue that until you're into your 70s. And at that point, it's not clear that it's going to do much more for you. And if you're also taking care of your general health, then you're doing everything you can do right now. That's why you need to join an advocacy group, because that's not very much. Especially when I told you that net, our vaunted net of breast cancer early detection, if we do it right, misses 70% of the women who fall off the trapeze, right? They still end up, if they're going to die of breast cancer, they're going to die whether they had a mammogram or not, and that's unacceptable.
But you can catch getting into that 30%.
If I had something I could do that would lower my chance of dying in the next 20 years by 30%, I would do it in a second. So I'm not saying mammograms shouldn't be done. I'm just saying they can become a mind-numbing, reality-blurring, Wizard of Oz kind of divorcing yourself from reality. That's a real good feel-good, but it leaves you in some danger and not having done something you could do, which is acknowledge that. Don't let it ruin your life, but acknowledge that we're not where we want to be with breast cancer, and do something about it. You know, hold your government's feet and the scientific community that live off government grants to the fire, and say, you know, we want this to stay on your radar screen, and we specifically have these goals for women that we want things focused on. And that's a very important thing. That's the only way this is going to get better.
Advocacy and personal health.
Right.
Put them together.
Right.
Yes, makes sense. We are unfortunately out of time, but Dr. John Glaspy, thank you very much for your time and expertise today, and let's learn something from this.
Okay.